Hello, my name is Deanna Cornish, and I'm the Director of Physician Coding at Rush. As many of you are aware, there are some big changes coming in 2021 for E&M services that will be effective January 1st. I've put together a PowerPoint to hopefully help provide more information on these upcoming changes. The following 2021 E&M information applies to E&M office visits only and will become active January 1st. The documentation requirements do not change for other E&M services that you might perform. AWBs, other preventive services, nursing home, if you see patients in the hospital, ER, etc. Only for office visit E&M codes between 99202 and 99215. The 95 and 97 E&M coding guidelines are not an option to use for office visits starting January 1st. As I have heard in other webinars that I've listened to, work has begun revising other E&M services. No dates have been given, but we do know this will not be effective in 2021. Here's just a summary of major E&M revisions for 2021. Extensive E&M guideline additions, revisions, and restructuring. The deletion of code 99201 and revision of codes 99202 through 99215. The reason for the deletion of 99201 is that 99201 and 99202 both had straightforward medical decision making, and of course 99201 would be your lowest level for a new patient. The components for code selection will now be medical decision making or total time on the date of the encounter. E&M level of service for office services can be based on, again, medical decision making. There has been extensive clarifications provided in the guidelines to define elements of medical decision making, and time. Total time spent on the date of the encounter. This now includes non-face-to-face services in addition to face-to-face. Clear time ranges have been provided for each code. And again, if using time, this means total time on the date of the encounter, which is important. It has to be the date of the visit encounter. Here's a chart I've made to show the code descriptions come 2021. There's a column for new patient and a column for established patient. You will see the 99201 will be deleted as of January 1st. 99211, the time component has been removed as of January 1st. 99211 is normally what we think of as your nursing encounters. Each code, now you can see the descriptions for each and the level of medical decision making that correlates with each code. So your lows would be your level 3s, depending on new or established, 99203 or 99213. And also I've given the time for each E&M code. Selecting a level of service, then and now. The first box is what we are used to for a long time, how we're currently doing it. The appropriate level of E&M services based on the following key components: history, exam, and medical decision making. Or time has always been an option to use. The current time rules, it has to be when counseling and or coordination of care dominates more than 50% of the encounter with the patient and or family. Only face-to-face time in the office on the date of the encounter. Come 2021, the appropriate level of E&M service is based on the following: the level of the medical decision making as defined for each service, or the total time for E&M services performed on the date of the encounter. The new time rules come 2021 will be whether it doesn't matter if counseling and or coordination of care dominates the service. This will include physician or other QHP face-to-face and non-face-to-face time. We will discuss more later in detail. History and or examination 2021. The extent of history and physical examination is not an element in selection of office or other outpatient services. However, please continue to document clinically pertinent history and/or exam. As a coder, it will be helpful for us because there's information that we do have to pull in selecting appropriate diagnosis codes. Example, if a patient comes in with an injury, we would still need to know how it happened and when it happened. So please continue to document the clinically pertinent history and/or exam, even though it is no longer a requirement in your code selection. Medical decision making, effective January 1st. Level of medical decision making table. It's a guide to assist in selecting the level of MDM. And again, this is only going to be used for your office or other outpatient E&M services. It includes 4 levels of medical decision making, which is really unchanged from current levels of medical decision making. You have straightforward, low, moderate, and high. Medical decision making table, then and now. What makes up the table for medical decision making? Well, currently, you have the number of diagnosis or management options, amount and/or complexity of data to be reviewed, and risk of complications and/or morbidity or mortality. Effective January 1st, 2021, number and complexity of problems addressed at the encounter. That is something they added to ensure when we're calculating our E&M level, that we are only choosing the problems addressed at the encounter. Amount and/or complexity of data to be reviewed, and they have also added and analyzed. Risk of complications and/or morbidity or mortality of patient management. In the medical decision making table, the first one we mentioned was number and complexity of problems addressed at the encounter. Straightforward will be more of your self-limited problems. Low, stable, uncomplicated, single problem. Moderate, multiple problems, or the patient is significantly ill. Or high, the patient being very ill. And here I've just listed some important definitions regarding the number and complexity of problems addressed at the encounter. You can see I've highlighted some things. I probably went a little overboard with highlighting. I'm not going to read all this to you. The one thing I did want to read would be the problem address definition. Notation in the patient's medical record that another professional is managing the problem without additional assessment or care coordination documented does not qualify as being addressed or managed by the physician or other QHP. Referral without evaluation by history, exam, or diagnostic study or consideration of treatment does not qualify as being addressed or managed by the physician or other QHP reporting the service. Again, this is why they emphasized when they updated the number and complexity of problems, it is what is being addressed at the encounter. And within the medical decision-making table, the second one we mentioned is the amount and/or complexity of data to be reviewed and analyzed. Data are divided into 3 categories: tests, documents, orders, or independent historians. Each unique test, order, or document is counted to meet a threshold number. Unique test would basically equal a single CPT code. Examples that I gave are your EKG would be 1, CBC, any lab, any single CPT. Independent interpretation of tests that are not separately reported. Discussion of management or test interpretation with external physician, other QHP, appropriate source that's not separately reported. Your straightforward be minimal or none. Low, which would be 1 category only, 2 documents or independent historian. Moderate, 1 category only. Count 3 items between documents and independent historian, or interpret or confer. High, 2 categories using the same concept as moderate. And again, I've provided some important definitions. I did want to mention on test, each unique test, a clinical laboratory panel, such as a BMP, is a single test. Even though multiple tests are made up of that one code. And then I also wanted to mention the independent historian, an individual parent, guardian, surrogate, spouse, witness who provides a history in addition to a history provided by the patient who is unable to provide a complete or reliable history. I know in the past, us as coders have had questions regarding a minor if the historian would be the parent. And the webinar that I did listen to, AMA provided some clarification on that. That did say a minor that where the parent is given the history, you can count that as an independent historian. I'm not going to read all of this to you, but to the side in a box, I have what does not separately reported mean. If the physician interpreted the test and is billing for that interpretation, do not include the test in determining the level of E&M service. If the physician is reviewing an image but it's not billed for, separately reported, it's part of medical decision making and selecting the level of service. Just don't double count time or work when a service is being separately reported. An example. If billing for an EMG, don't include the EMG as data in determining your E&M. Don't include the time of the EMG if using time. When the provider or provider in the same specialty or practice will bill for this service separately, which would of course be another CPT code in addition to the E&M, the service has been reported separately. Another example of that would be your EKGs. And the last component of the medical decision-making table is the risk of complications and or morbidity or mortality of patient management. Risk of complications and or morbidity or mortality of patient management decisions made at the visit associated with the patient's problems or treatments. Includes possible management options selected and those considered but not selected. Addresses risk associated with social determinants of health. Straightforward, minimal risk for treatment, including no treatment or testing. Most would consider this effectively as no risk. Low would be your very low risk of severity, minimal consent discussion. Moderate would typically review with patient, surrogate, obtain consent, and monitor, or there are complex social factors in management. And then you have high. Need to discuss higher risk problems that could happen for which physician or other QHP will watch or monitor. And again, I've included some important definitions on that. Risk, morbidity, social determinants of health, drug therapy requiring intensive monitoring for toxicity. I know there's always been questions for that, wondering what exactly would fall into that category. I guess because there have been so many questions on that, they have given a definition, some clarification. So I will not read that to you, but you can read that to see what determines the drug therapy requiring intensive monitoring for toxicity. And here is the medical decision-making table, all put together, the elements of medical decision-making. The first column, you will find the CPT codes, the E&M codes. Then the next column, it will give you the time associated with each of those codes. The level of medical decision-making, which we'll talk again in a minute about, is based on 2 out of the 3 elements of MDM. You have straightforward, low, moderate, and high. Then the next column, number and complexity of problems addressed. Then amount and or complexity of data to be reviewed and analyzed. And then risk of complications and or morbidity or mortality of patient management. And here's an actual example of calculating an E&M level based on your medical decision making. To qualify for a particular level of medical decision making, 2 of the 3 elements for that level of decision making must be met or exceeded. So you can see the first column. I have chosen 99204 or 99214, depending on if it's a new or established patient. And the reason we got to that level was under the number and complexity of problems addressed. Let's say the patient had 2 or more stable chronic illnesses during the encounter. The amount and or complexity of data to be reviewed or analyzed, let's say none, we didn't have any of that. And then the risk of complications and or morbidity or mortality of the patient. You can see that I circled prescription drug management, and I did want to add to that drug management. Prescription drug management would be anytime you continue a medication, renew medication, or even change medication. All of that is considered prescription drug management if this is decided after evaluating the patient. So after we've circled where we fill in the columns, you can see 2 out of 3 is why I chose the 99204 or 99214. And I also wanted to add a change from what used to be in the low risk of complication is the over-the-counter meds. It has been removed due to controversy because they say some over-the-counter meds in patients with other certain medical conditions could cause significant risk. So they're leaving that up to the providers to decide where that patient would fall in the risk of complications due to over-the-counter meds. Another way of choosing your E&M level would be basing it off of the time. This is the total time on the date of the encounter. Includes physician, other QHP face-to-face, and non-face-to-face time. The non-face-to-face is new for 2021. It used to be only face-to-face. The time spent by clinical staff is not included. Is for code selection when using time, not a required minimum amount when you're using medical decision making instead. Physician or other QHP time includes the following activities when performed: preparing to see the patient, reviewing the test, obtaining and or reviewing separately obtained history, performing medically necessary appropriate examination and or evaluation, counseling and educating the patient, family, or caregiver, ordering medications, tests, or procedures, referring and communicating with other health professionals when it's not being separately recorded, documenting clinical information in the electronic or other health record. But please remember, in order to use the time for documenting in the electronic health record, it must be done the day of encounter to be able to use it. If it's done the next day, you cannot add that towards your time. Independently interpreting results that are not separately reported and communicating results to the patient, family, caregiver, or care coordination not reported separately. So the time face-to-face or non-face-to-face that was done that day of the encounter. And just a little note, there have not really been guidelines on exact documentation to be able to report using time. When using total time spent, documentation must support the service being based on time. Best practice is to document the reason as to why time is being used to determine the level of service over medical decision making. Example, details of what occurred during the visit that led to an extended amount of time being spent. And of course, you also must document the total time spent. And here I've provided 2 links that have been helpful for me regarding the 2021 evaluation of management changes. I will continue to keep you updated with the latest information and will provide more information at a later date regarding applying these new guidelines to our EMR, which is HAC. Please call or email me with any questions you have in the meantime. I will do my best to answer them, and if I'm not sure, I will definitely research and get back with you with those answers. I'm hoping we have a smooth transition come January 1st with these new changes, and I will keep you posted as I hear more, and we'll get back with you soon. Thank you.